hope to make it to the end of this session and then also the debate. So, take the blue one. Okay, can you hear me? Roughly. Okay, this is what's called my sexy voice. Okay. So I work in London. I don't have a map. I'm the director of a nursing research centre, which hosts a number of research groups within it. But the most mature of those groups is the one that I've led for about the last 10 years, but have worked in since 1998. And that particular group is focused on infection prevention and control, the evidence for infection prevention and control, and changing practice so that we can keep patients safe wherever they are in our healthcare settings. So I'm going to talk a little bit about the guidelines that we have developed a number of times. So we started in 1998, published our first set of guidelines in 2001, and then have updated those guidelines as we've gone along. But then I'm going to talk about the problems, to some extent, that underpin the evidence for infection prevention control and the impact that has on, if you like, how we're trying to implement them. So the national guidelines are called the EPIC 3 guidelines. The mnemonic stands for Evidence-Based Practice in Infection Control. And that came to me in the middle of the night, one night when I was buried in looking through assessments, what can we call them? So they actually have 3 core components. The first is what we would call, if you like, the fundamentals or the standard principles of infection prevention and control. And then there are 2 major groups of invasive devices that are associated with a large number of infections, and those are urethral catheters and intravascular access devices, both central and peripheral. So we actually use the SIGN methodology that Kay spoke about yesterday, and we've used that since the beginning, and so therefore we've continued to use that in the iterations that have followed on. So the SIGN methodology essentially starts, as does all guideline development, as Holger spoke about on yesterday as well, with looking at what stakeholders think are the questions that we need to look at. And the original guidelines, the stakeholders were the government predominantly, but as we've developed over the years, we've taken a much broader perspective on who stakeholders are, and that includes organisations that represent patients who have either suffered or had relatives who've suffered from an infection whilst in healthcare. So those particular scoping exercises direct our protocol, our questions and protocol developments. We have a guideline development advisory group which consists of patients, physicians, microbiologists, nurses, infection control practitioners. We search for guidelines, we agree those. I think Miroslav talked about actually adopting guidelines where you can rather than reinventing the wheel. So searching for whether or not they are applicable, whether they meet your context and whether they have the types of evidence that you're actually looking for. And then looking for new studies, appraising those and getting the data together. So in all of the iterations, we've only included study designs that are primary research, somewhat wistfully hoping that we might find RCTs, cluster RCTs, but in fact there are very few of those in infection prevention and control, and using secondary research, but only systematic reviews and meta-analyses, which we then take the studies from and re-synthesize. The SIGN levels of evidence for studies are actually follow this format, and the 4th one is expert opinion here, which was spoken about yesterday, and it's something that I'll come back to. So the levels of evidence that we don't accept for guideline development are those with high risks of bias and therefore non-analytic studies. So the guideline process, after you've done all the sifting, appraising, extracting, in the SIGN methodology actually results in what's called a considered judgment process. And in that process for the EPIC guidelines, we use the evidence for what existed before, what new guidelines we'd identified with new evidence, our own new evidence. We have patients who provide their views and experience. We have to look at health and safety regulations and also legal frameworks around some of the things we're doing, and then the guideline is drafted. And the guideline is drafted with recommendations that follow these grades. At the moment, we don't use the grade approach, although the next iteration, we are actually going to completely revamp the guidelines to actually include grade. So once we have when we have the considered judgment meetings, we actually then look at where we would make the recommendations and at what level they actually appear. The guidelines then go through a process of consultation, which is the second opportunity for stakeholders who've registered an interest to actually feedback to us whether the guideline recommendations fit their perception of what's needed, but also they can produce additional evidence if they need to. I particularly loathe this section because to some degree it is the opportunity for you to be derailed by vested interests from industry, but also patient groups. So you have to be very careful about how you interpret the consultation you get back by taking account of the comments that come, but going through the same sort of process in terms of ensuring that you're not being swayed away from the evidence in a particular way. Guidelines revised. For our guidance, they actually go through the policy research programme for NIHR that commissioned them. We end up with the final guidelines, and then we went through the process of getting NICE accreditation so that the healthcare settings know that these guidelines are actually developed in a way that meets the requirement for them to be used in practice. And to some extent, that's quite an important element of trying to make sure that they are used and that they do drive policy. So if I talk about the issues for evidence, because that's the major problem. So if you look at this, what we find is that many of the study designs are convenience designs. They're single centre. They're often before or after studies that have very little control. They are interrupted time series with insufficient numbers of observations before an intervention is introduced or after the intervention is introduced. The study settings are very heterogeneous, so you have studies that are in ICUs that are very different to medical wards or surgical units. You have a lot of differences in actually some of the interventions, and so things like chlorhexidine gluconate and how it's used in studies. So you might say, let's look at chlorhexidine gluconate, but you have to be really careful about stipulating which particular preparation, at what strength, and in what format in order to inform your questions. And there are lots of studies, again, sort of to some extent, driven by industry around what works and what doesn't work. And then I think one of the others is a sort of major confounding issue, which to some extent is driven by our need to improve quality, our need to keep patients safe, and that what people do is they introduce something that sounds like a good idea at the time that studies are going on. And so there might be other quality improvement measures or bundles of interventions where you don't actually know what the effect is. So one of the problems for these types of guidelines is that you're trying to get staff to put their practice on the best available guidance that you have, but some of that is simply good practice. And it makes sense. It is scientifically, if you like, in terms of microbiological logic, the right sort of things to do. But even hand hygiene, which we talk about constantly, the evidence base for that is not an A-level evidence base. It's not at the highest level you can find. The other thing is that there are a lot of implementation studies, and I think it's really important, I think, in the future that we start to look at developing guidelines that are based on both evidence of effectiveness, but also on the evidence that those effective interventions can be implemented, and that should form part of the guidelines that we produce in future. It's beginning to be done in the UK. NICE has a process where you have to look at the implementability, but that doesn't necessarily have to be underpinned by research that has been undertaken in those interventions. But some of the implementation studies are problematic in their design as well. They're often very descriptive, and that's really helpful if you're trying to understand context that Judith just identified as being really, really important. But they often give an inadequate description of that. So it will be a very superficial description, and you'll be unable to work out whether or not the context in which that has been implemented is the same as your own. Often baseline measurement is omitted, or you get a single baseline measure. So you might have a single audit of hand hygiene or a single audit of peripheral vascular catheter insertions, and then people look at whether or not they can improve on that. Well, that's insufficient. That's not appropriate. It's much better to use approaches that perhaps use statistical process control, where you have a number of measures beforehand, very similar to an ITS design, and then you can look at whether or not your interventions are implemented and that the change is sustained over time. Measurement is often not a process that is highlighted in implementation studies. There are lots of process measures, but outcome measures tend to be forgotten because they're, well, not forgotten, I think they're actually in the too difficult box in some instances. And so trying to measure outcome and sustainability or stickability is the term that Joe Rycroft Malone would use, is something that isn't necessarily always reported. And I'm going to come to a couple of studies where, we think these things work, but when they're transferred into other contexts, simply don't have the same impact. And there's also the tendency to roll out multiple interventions at the same time in order to sort out a problem. So an example in the UK is that we had a major issue with methicillin-resistant Staph aureus infections, and we had a sort of a 4-year programme of interventions to prevent those or reduce them by 50%, a target that was set by the government. But in evaluating that particular programme, it was really, really difficult to actually sort out where we had had impact in terms of what it was we did, because basically we threw the whole kitchen sink and every kitchen cupboard's contents at the problem over those 4 years. So we get to this issue that has been referred to a couple of times this morning about the fact we have the evidence, we have the guideline, we want to change something and we want to get a desired outcome at the end of it. But we have this then gap, which is the world of evidence, the world of implementation, and the world of practice. And I'm very keen on looking at some of the work of a chap called Eric Holnagel, who's started to look at the fact that what we actually do when we're trying to improve safe systems, and this is why infection prevention and control sits in this particular field, is that in many ways, I think, as evidence synthesizers and implementation improvement scientists and practitioners, we have a stylized and perfect view of what practice should be. And that is what Holnagel calls work as imagined. But in fact, when you go into practice and you spend time, what I call lurking or observing what's going on, what you actually have is work as done. You see what it is that's happening in practice and how your best efforts at making a guideline implementable can go completely awry. So this idea that what we need to do is stop considering evidence as work as imagined and take that into what is, if you like, the real world of practice, is something that I think we need to pay quite a lot of attention to. So in infection prevention and control, one of the major problems is that in fact it's actually seen as an add-on. Now, when I was a student, which is a very long time ago, around 40 years now, this was part of everything you did. It was basically drummed into you from a very early age as a student nurse. But that's not happening anymore. It's actually seen as something that is additional. It's not embedded in real tasks. It's seen as a distraction, sometimes an interruption to the important things they have to do. And in some ways, unlike other interventions, the benefits aren't visible. Preventing something isn't visible. It's amorphous, it's grey. And the harms can often be distant. I'm unsure about your own healthcare system, but in the UK, our patients in acute care are only in hospital for a very, very, very short time, unless they're critically ill, and then they're in whilst they're critically ill and then discharged quite quickly. So sometimes the impact of infection doesn't actually happen until a way down the road. And it's not associated with the fact that I did something wrong, or we as a team did something wrong, or we as a system have actually failed the person who got the infection. And so what staff do is they develop what Carla Alvarado calls workarounds or shadow systems to achieve the task. They do things in a way that isn't visible and you can't actually audit or see it. And some of those are actually very good workarounds, and what Holnagel actually focuses on is that actually what we tend to do is look at what's wrong with what people do rather than what's right. And actually if what we did was focus on work as done and done well, we would actually learn an enormous amount about how people do these workarounds and those that actually could be used to help things stick. That also sort of fits with some of the theories around positive deviance, so actually finding people who do things well in a particular way and using them as examples within implementation. So I'm just going to talk about a study that is focused on implementation of the use of clinical gloves, because clinical glove use is part of the EPIC guidelines. It's been part of standard precautions since the mid-90s, became part of absolute standard practice during the HIV epidemic in the 1980s, and to some extent has become a sort of a ubiquitous so-called infection prevention intervention. And the evidence for the use of gloves is categorized as level 4. Many of the studies are very old. They come from the 1980s. They are related to gloves that were imperfect at the time, where manufacturing has actually changed. And so a lot of the thing is, oh God, really?
It's okay.
We got a bit of time?
Yeah, we've got
Okay. Okay, so why do gloves matter? So they compromise hand hygiene. They're costly. So in one hospital, you could save £250,000 if you didn't use them as much. And they cause environmental damage. If they are worn, they must be changed between patients. They must be changed between procedures. And you have to decontaminate your hands after removal. We know that gloves are worn inappropriately. That's been seen in a number of studies in the past. And that also when they're worn inappropriately, they become contaminated and therefore they can become important in the transmission of infection. So in our study, we actually looked at the moments of hand hygiene that were associated with cross-contamination when gloves were used. And what people do is they put gloves on, they never take them off, they continue to actually deliver care, and they put patients at risk. Now, the most important moment, as far as I'm concerned, is this one, moment 2. I can put those two together and say, you know, moment 1 and 2, as far as I'm concerned, if I'm a patient or as a member of staff, as long as people clean their hands before they touch me or something that goes into me that breaches my defences, I'm happy. So you can see that the moments breached most frequently are moments 1 and moments 2. So we are actually putting our patients at risk. The things that happen when people use their gloves in that way is, so they're giving IV drugs, so straight into venous access. They use the same gloves more than once for nasogastric feeding, urinary catheter changing, endotracheal suctioning. You can see in this one actually a sort of a series of events that happened in terms of where things were critical. So gloves were worn to do these things and then flush a line, touch the IV monitor, went to the central line, IV infusion lines, central line, flush again, IV pump. That's all without a single change of gloves. And then the same gloves in more than one task here, emptied a catheter tag, then gave the patient mouth care, and then checked the patient's blood sugar. As far as I'm concerned, horrendous practice. But what we were concerned with, in order to understand that and change what people do, you have to know what motivates them. Bridie talked about that. And so whilst we wanted to observe practice, what we really wanted to know is why people do the things they do in the way they do them. And a really huge part of this study demonstrated that there's a huge amount of emotion attached to gloves in terms of them thinking that they're a psychological barrier, they're a physical barrier, they feel safe. Patients are dirty. I don't know if you knew that. Every patient you touch is dirty as far as staff are concerned. And there's a lot of fear. So things which are actually really strong emotions drive people's glove use behaviour. The socialisation things, I think, are all things that we might expect, particularly in terms of organisational and professional. But the issues around sort of empathetic socialisation, so actually being in empathy with your patients, that actually changed some people's use. They thought a little bit more about it, but they still felt that actually staff preference, so what you felt was good for you, was one of the most important things to actually do. And so we learnt that lots of things actually impact on glove use, and that if we're trying to change this, we have to think about the motivations and the emotions in order to change that practice. And we're in the process of doing a number of studies to do that, but this work has been picked up by very many NHS trusts in the UK in order to change people's behaviour, and we're working with them to try and see what that does. Now, this evidence, you may all remember, is really important in terms of changing the way in which we looked after central vascular access lines. It's work by Peter Provenost. It was then it was demonstrated to be highly effective in the US, and their central line bloodstream infections dropped like a stone. We then tried to implement it in the UK, and it didn't really work. And there were lots of reasons why it didn't really work. And there are lots of reasons why a similar intervention around managing urinary catheters didn't work. But to some extent, they're to do with this. I don't know why it's done that. That says checklists. It's not written in Czech. But this is so why checklists fail. And essentially, we are beginning to put everything on a checklist. So if you actually go to a person's bed space, you will find, okay, that they don't, checklists aren't filled in. There may be 10, they're not integrated, and people just don't follow them. So we're allergic to change. We've always done it this way, and we try and get people to change that. I quite like this quote by Grace Hopper, because I think de-implementation is one of the most difficult things to do. To actually stop people doing something that they have always done is really, really difficult. And this work, which is based on a Cochrane review, it's done by Claire Rickard and her team in Australia, and they demonstrated that actually you can save the patient discomfort, you can make a patient safer, and you can save money if actually what you do is you don't routinely recite IV lines every 3 days. And she has taken a huge amount of fairly controversial criticism, both in Australia and other areas, for this particular review, and the changes in practice that drive from it. And so when we're trying to implement things, we also have to try and de-implement as well. And that's where this approach to looking at behaviour and motivation and what people are doing is really, really important. So in terms of evidence, we need to educate, engage and enable in order to change the context of care. And that's my team. Thank you very much indeed.